Clinical Judgment, Week 10. We now have a client who's a 57-year-old male admitted with pain and a rash from his left neck extending around to under his left axilla. And this is what the assessment findings are. He reports pain 8 out of 10. His blood pressure is 136/88. 88. His lungs are clear to auscultation. He has a rash from the left neck to the left axilla. The rash has pustules and open lesions with some clear exudate and crusting. He is taking ibuprofen without relief. His temperature is 100.2 oral. Respiratory rate is 16 breaths per minute. He's applying calamine lotion with minimal relief. He lives alone. His heart rate is 98 beats per minute. He reports moderate pruritus and active bowel sounds ×4. Again, look at all of these findings. Determine what findings are relevant or most important at this time. And again, it can be something that is a normal finding. It can be something that is abnormal. And this is what I have picked out. What could be causing that elevated pain? Well, maybe he had an injury of some type. Maybe he has some type of an illness. Well, shingles can cause a lot of pain. Maybe he has tissue hypoxia, which can cause severe pain. How about that rash from the left neck to the left axilla? Well, we know that this could be just an allergic reaction. Again, might be shingles. Shingles do follow a dermatome, so it kind of wraps around the body. It may be from chickenpox or dermatitis or psoriasis or eczema. That rash with pustules and an open lesion with some clear exudate and crusting. This is very typical of shingles and or chickenpox. Taking ibuprofen without relief. Well, maybe this is the wrong medication or maybe the wrong dosage. It could be that the pain is just too severe for this medication, or he has a tolerance to ibuprofen. That elevated temperature, 100.2, probably not that high because of exertion or too many clothes or too many layers, but definitely could be caused by an infection. And that infection could be a virus or a bacteria. Could also be caused from the shingles or chickenpox. Applying calamine lotion with minimal relief. Well, calamine, if you are not aware of what calamine is an antipyretic medication. It's that nice pink stuff, liquid that you dab on areas that are itching. Maybe it is not the appropriate antipyretic medication. Maybe there's something better out there that might help. And complaint of moderate pruritus. Again, allergy, shingles, chickenpox, dermatitis, psoriasis, eczema. So it could be from a variety of things. You notice I did not put the blood pressure there, which was on the higher side. It's really not pertinent in this case. So what are potential complications? Well, when you have pain that high, it can definitely lead to depression, irritability. With a rash, we're looking at potential skin impairment uh, or infection with those pustules and open lesions. There is a potential for overdose if they're taking ibuprofen without relief. If that didn't work, let me try something more. That elevated temperature could lead to dehydration, and if it is an infection, if it's bacterial, could potentially lead to sepsis. The calamine lotion with minimal relief, well, if it's not relieving anything, we're still looking at skin impairment, as we are with the complaint of the moderate pruritus. Doubled up. So what do we think is going on? Well, I'm of the opinion that this is probably shingles. So priorities are going to be potential skin impairment and the pain. If you remember from our studies, pain is a significant issue with herpes zoster. We expect the skin to be free of infection, rash, or any lasting injuries, and we expect there to be minimal to no pain. Although we do know that post-herpetic pain can continue for years after the episode of shingles. So is there anything that we should avoid? Well, this client should avoid contact with anyone who's not had the chicken pox or who has not been vaccinated for the chicken pox. So what are we going to do? Well, we definitely need to monitor vital signs, making sure that the blood pressure doesn't go any higher, making sure that that temperature doesn't go any higher or hopefully comes down. We're probably going to give opioid analgesics in this case. We could give some antivirals if the client has come in within 48 hours of symptom onset. We could do that orally or topically. We can give antipyretic medications. Cool packs would feel very good. Distraction. Until they are not contagious, they should be isolated. And then we also need to educate the client on skin care and isolation techniques. So we looked at our priority issues, which is going to be no skin impairment and minimal to no pain. What are we going to do? Well, antivirals, antipyretics, education on skin care. The pain would be opioid analgesics, the antivirals, cool packs, distraction. So what ones of those might be the most important? Well, let's take care of that pain. Give him the opioid analgesics, then determine if it is appropriate to administer those antivirals. If it's been less than 48 hours from symptom onset, the antivirals can be very beneficial, and then give some antipyretics. And as always, the last step would be evaluation. Have we achieved our goals? If we have not achieved our goals, what do we need to change? Which client do we need to see first? Is it the client who is bedfast and unable to reposition themselves? Is it the client who is bedfast and able to reposition themselves? Is it the client with a chronic peripheral arterial disease ulcer with a dry wound bed and pain 4 out of 10? Or is it the client with chronic peripheral venous disease ulcer with a wound bed that is draining copious amounts of serous exudate? Well, I'm going to say the correct answer is number one, because if we do not reposition the client, do a skin assessment, this client could potentially have skin breakdown, which can lead to some serious complications. If they're able to reposition themselves, that's great. We expect a chronic PAD ulcer to have a dry wound bed and some pain. We expect a chronic venous ulcer to have copious amounts of serous exudate. So which clients are going to be at risk for pressure ulcers? This question is just basically asking what are risks for pressure ulcers or pressure injuries? Would it be a confused client who likes to wander through the halls? No, they're up moving around. Would it be a middle-aged quadriplegic client who is alert and conversant? Yes, if they're quadriplegic, not only do they have some paralysis, but they have a loss of sensation. They do not know if they are developing a pressure injury. Is it a bedridden client who is in the late stage of Alzheimer's? Yes, they do not recognize what could be causing their pain. They are unable to respond appropriately with repositioning. Is it a very overweight client who must be assisted to move in the bed? Yes, this client has decreased mobility, a decreased ability to reposition themselves. Would it be an ambulatory client who has occasional urinary incontinence? Yeah, urinary incontinence is going to increase the risk for skin breakdown, but the client is ambulatory and it is only occasional urinary incontinence. So, no. Or would it be a thin client who sits for long periods of time and refuses meals? Well, this client is immobile for long periods of time and is most likely malnourished. This can lead to the development of pressure injuries. So the correct answers 2, 3, 4, and 6. For which action must the nurse intervene when a nurse is providing care for a client with increased risk for pressure ulcer development? Well, first of all, we're wanting to intervene, so that means we're looking for something that has been done incorrectly or something that is wrong. And then we also really need to know what the appropriate treatment for pressure injuries is. Is it the student assists the client to consume most of the lunch tray? No, we want them to eat. Would it be the student provides assistance with bathing of the back, lower legs, and feet? Would it be the student massages reddened areas over the coccyx region? Or would it be the student reminds the client to change positions every 2 hours? Well, we know we need the client to change positions. Assisting with bathing, this is good. There's going to be areas the client cannot reach. But we do not want to massage reddened areas because we already have some skin impairment there. We could actually cause a worsening of the skin impairment by massaging reddened areas, especially over a pressure area. The nurse is now caring for several clients who have sustained burns. The client with which initial injury is least likely to experience severe pain when a sharp stimulus is applied? Well, we know we have burns, so basically this question is asking what burn causes minimal pain? Is it a severe sunburn after lying in the sun for several hours? Is it a deep, full thickness burn from an electrical accident? Is it a partial thickness burn from picking up a hot pan? Is it a deep partial thickness burn after a motorcycle accident? Remember, our full thickness burns are not going to have pain because the burn has also destroyed the nerve endings. Correct answer is number 2. In this question, we have a client who sustained a superficial thickness burn over a large area of the body. The client is crying with discomfort and is very concerned about the long-term effects. What does the nurse tell the client to expect? So what is this client or question asking? Basically, what do we see with superficial thickness burns and how do they heal? Is it healing should occur in 3 to 6 days with no scarring or complications? The pain should be less because more of the nerve endings were destroyed. Is it the wound will appear red and dry with some white areas? Is it the leathery eschar will have to be removed before healing can occur? Responses 2, 3, and 4 are all description of a full thickness burn. Only number 1 is going to be the superficial thickness. Correct answer, number 1. Now we have a thin, malnourished client requiring emergency abdominal surgery. After the operation, in order to promote wound healing, what does the nurse encourage? What is this question asking? Well, it says right here, we're promoting wound healing. What do we encourage? So basically, what improves wound healing? Is it a high calorie diet? Is it a low sodium and low carbohydrate diet? Is it a high quality protein diet? Is it a low fat diet with vitamin supplement? Well, we know that we need protein for healing, whether it is a wound or an illness, and we need high quality protein. Correct answer, number 3. Last question. The nurse is caring for a client in a prolonged coma after a serious head injury. The nurse uses which interventions to prevent the development of pressure ulcers for this client? What is this question asking? How do we prevent pressure injuries? Do we use pillows or padding devices to keep heels pressure free? Yes. Is it assess heel positioning every 8 hours? 8 hours is a long time. We need to be assessing them more frequently. Is it delegate turning and positioning every 2 hours? Yes. We definitely need to make sure that the client is repositioned at least every 2 hours, and the UAPs can do this. Is it obtain an order for pressure relief devices? Most definitely. For example, we need the pressure relief mattress, whether it is an egg crate mattress or an air mattress, etc. Would we give special attention to fleshy or muscular areas? This is not an area where pressure injuries are likely to develop, so we need to be looking at the bony pressure points. So number 5 and number 2 are both incorrect.